critical care for MRCS Part B. We are approaching the critical care same way as the exam, and the resource we are using in this material is our classroom in school. We'll start the first station in the cardiovascular system series. The first station is hypotension and bradycardia in a pregnant lady. Okay, so as you can see, the station will be in a question and answer format, same as MRCS Part B format. Alright, we'll start with the scenario. The title is Hypotension and Bradycardia in Pregnant Lady. Clinical scenario: a 34-week pregnant woman is undergoing an open cholecystectomy and the epidural anesthesia for necrotizing cholecystitis. During the operation, she became hypotensive, blood pressure 78/45, and bradycardic, heart rate is 42. You are the surgical trainee asked to assist in managing the situation. First, understanding the clinical indication. Was this surgery necessary despite the pregnancy? The answer is yes. The patient has necrotizing cholecystitis, which require urgent source control to prevent sepsis, peritonitis, and multi-organ failure. Delaying surgery would risk both maternal and fetal death. Surgical indication and conservative alternative. What is your management if the patient is deteriorating and unstable? Proceed with early open cholecystectomy if vitally unstable but surgically correctable. If the patient is unfit for surgery, what should be done? Perform percutaneous cholecystectomy to control the infection and avoid general anesthesia. If the patient refuses surgery, what's the conservative approach? Begin IV fluid, antibiotics, analgesia, and offer urocidol or chinodoil to thin the bile. Discuss risk of non-operative management thoroughly. Pathophysiology of intraoperative hypotension and bradycardia. Why did the patient become hypotensive during the operation? For 3 reasons. Firstly, the inferior vena cava (IVC) compression by the gravid uterus will lead to decrease of the preload, as shown in this image. As you can see in this image here, the gravid uterus presses on the inferior vena cava, and this will lead to decreasing the preload, which will decrease the blood pressure. Epidural anesthesia will lead to sympathetic blockade, which will lead to vasodilation, which will also reduce the total peripheral resistance and thus reduce the blood pressure. Sepsis-related vasodilation also a possible cause because the lady has necrotizing cholecystitis, which may lead to sepsis, which may lead to systemic vascular resistance, decreasing in systemic vascular resistance. Why did she also develop bradycardia? She developed bradycardia because of the vagal reflex triggered by traction on the peritoneum or uterus, and also it's enhanced by epidural anesthesia. So 2 reasons for bradycardia. Immediate intraoperative management. What are your steps to correct the hypotension and bradycardia? Left lateral tilt or manual uterine displacement. So you will put your patient on the left lateral position. Elevate the legs to improve the venous retain. IV fluid bolus, specifically crystalloids. Administer vasopressor like phenylephrine 50 to 100 microgram. Call anesthetist and obstetrician immediately. Start fetal monitoring. Prevention of DVT. How can DVT be prevented in this patient postoperatively? Early mobilization, adequate hydration, mechanical methods like TETs and intermittent pneumatic compression, and pharmacological prophylaxis if stable, like low molecular weight heparin. This image shows you the intermittent pneumatic compression. Applied physiology and hemodynamic. Define preload. Preload is the end diastolic ventricular volume, determining myocardial stretch before contraction. What factors affect preload? Venous pressure, venous retain, arterial contraction, ventricular compliance, heart rate, and valve resistance. How can preload be improved acutely? We can improve it acutely by IV fluid administration, inotropes or vasopressor, leg elevation, relief of IVC compression. How you can relieve the inferior vena cava compression by the gravid uterus, changing the lady position to the lateral side. Inotropes in management. What the effect of adrenergic and dopaminergic inotropes? Adrenergic, like noradrenaline, will increase contractility, will increase systemic vascular resistance, will increase mean arterial pressure, and will also increase organ perfusion. Dopaminergic, dose dependent, will decrease. Low dose will lead to renal vasodilation. Moderate dose will lead to cardiac increasing in cardiac output, and high dose will lead to increased systemic vascular resistance. Stroke volume and venous retain. How is stroke volume calculated? Stroke volume equal end diastolic volume minus end systolic volume, which is usually around 70 ml in an average adult. Compare venous retain in standing vs against spine position. In standing, this will lead to decreased venous retain due to gravity. In supine, this will lead to increased venous retain, but compromise in pregnancy due to inferior vena cava compression, as we said. Mechanism of compression stocking. Gradual pressure increase venous retain, reduce stasis, and prevent thrombosis. Neurohormonal reflex to hypotension. How does the body respond to hypotension? Decrease in baroreceptor firing will lead to increase in sympathetic tone, increase in heart rate, contractility, and vasoconstriction, and also hormonal. Catecholamine like adrenaline and noradrenaline will be increased. Mineralocorticoid like aldosterone will lead to salt and water retention. What are baroreceptors? Baroreceptors are stretch-sensitive receptors in carotid sinus and aortic arch, regulating short-term blood pressure via autonomic control. As you can see here in this diagram, imposed decrease in arterial blood pressure will lead to sensation by arterial baroreceptor as decreased stretch due to decreased blood pressure, of course. This will lead to decreased baroreceptor afferent nerve activity. This will lead to signal processed by medullary cardiovascular control pathway. This will lead to two outputs: increased sympathetic activity, which will lead to increased heart rate, increased force of heart contraction, and arteriolar vasoconstriction. This will also lead to decrease in parasympathetic activity, which will increase the heart rate. And the sum effect of both will lead to increased arterial blood pressure. Please refer to the diagram on the school platform. Management of frail of elderly patient. How would you manage a frail 90-year-old lady with acute cholecystitis? The answer will be conservative treatment: IV fluid, broad spectrum antibiotics, analgesia, consider uridine or chinodil. Treatment involved team involved and post-operative care. Team involvement and post-operative care. Which specialties should be involved? You will involve general surgeons, of course, obstetrician because she's pregnant, anesthetist, neonatologist, and HDU or ICU team. Where should the patient be cared for post-operation? In obstetric high dependency unit, HDU. Why? Because we need continuous maternal and fetal monitoring. This will include the first stage in cardiovascular critical care MRCS Part B.